Webinar is open and we are now recording.
I guess I'll kick it off here. I just want to say hi everyone. Thank you for joining us today during this this wonderful panel session that we have titled "Pressure Injury in Persons Living with Spinal Cord Injury." My name is Ryan Fairbrother. I'm a research assistant here at the Michael Smith Health Research BC, and I'll be the moderator today for this panel presentation. Just wanted to let everybody know that there will be a live question and answer session after the presentation. So if you could please use the Q&A feature at the bottom of your screen to ask those questions to the speakers. And when you ask your question, could you please add in the speaker that your question is directed to? If you'll be tweeting about the conference, we ask that you please use the hashtag PPF2022 in your tweets. And if you have any sort of technical questions, please go to the technical support page that can be found at the bottom towards the left side of the menu within the main conference platform. And now I'll pass it over to the panel to begin the conversation.
Thanks so much and welcome everyone. We're so grateful for you joining us today for this panel exploring pressure injury in persons living with spinal cord injury, a patient-driven research. My name's Davina Banner. I'm a researcher and nurse, and I'm based at the University of Northern British Columbia in Prince George, which is on the ancestral and unceded territory of the Lheidli T'enneh. And now I'm going to hand you over for introductions with each of our panel members, starting with Spring, then John, then Nassim.
Thank you, Dr. Banner-Lucaris. My name is Spring Hawes. I am the patient lead on this research project. I live in Kelowna, which is the unceded territory of the Silks people. And I'm just really grateful to be here today.
And hello, everybody. My name is John Cheresky. I am the manager of the Consumer Engagement Program at the Praxis Spinal Cord Institute in Vancouver. We are a translational research organization looking to accelerate the translation of novel ideas and technologies towards impact for persons with spinal cord injury. And I'm coming to you from the unceded territories of the Squamish, Tsleil-Waututh, and Musqueam nations.
Hello, my name is Nassim Adhami. I'm a postdoctoral research fellow at UNBC School of Nursing, and I'd like to acknowledge that I come to you from Vancouver, which is the traditional, ancestral, occupied, and unceded territories of the Musqueam First Nation.
And thank you so much, everyone, for joining us. And we do invite you to also share your land acknowledgements in the chats as you wish. Oops. Sorry, my slide is not advancing. There we go. So before we begin, we'd like to acknowledge the wider team. And so our team comprises diverse people with lived experience, researchers, knowledge users. And so we're very grateful for all of our team members who have contributed greatly to this work. We'd also like to take the chance to acknowledge our funders. This project was funded by the Canadian Institutes of Health Research, and also to our participants who have trusted us with their own stories and their own lived experiences and journeys along the way. So today we have a two-part panel. And first of all, we're going to open up by starting first of all about the collaborative partnership and how we built this team together. And then followed by that, our second part will be focused much more on what we've learned so far about the lived experience of living with risk of pressure injury for those living with spinal cord injury, from real world experiences to changes in practice and policy. Before we begin though, let's head over to John to learn more about spinal cord injury and pressure injury.
Thanks, Davina. So just to set a bit of context and make sure we all are on the same page and are coming from a similar place of knowledge, I'm just going to give you a quick overview of what spinal cord injury is and how it affects individuals that have incurred an injury such as this. Next slide, please. So the spinal cord is the primary conduit between the brain and the rest of the body. It runs inside your spinal vertebrae and is responsible for a host of functions and really is the primary messenger between the brain and the body. So I think for the lay audience, you may easily recognize the reduced mobility and impaired motor function as a result of spinal cord injury. But there are other changes that happen to the body as a result of the spinal cord injury, including reduced sensory function, so the ability to feel your body, as well as what we call the autonomic dysfunctions. So these are the functions that your body cannot volitionally control: your breathing, your temperature regulation, and such. And dependent where along the spinal column that you damage the spinal cord, it can have a vast difference in how much it affects your function on your body. So as you can see, the spinal cord is broken into various nerve branches from C1 all the way down to S5. And the higher up you impact the injury, the higher the level of dysfunction throughout your body is. So that's just a quick glimpse of what the spinal cord looks like and where it is and how it can affect your body dependent on the level of injury. Next slide, please. So as I said, the spinal cord injury affects far beyond just the motor paralysis. In fact, it can affect every physiological system in the body and can result in a huge array of secondary complications. I mentioned respiratory function and autonomic functions, but it can also affect your trunk mobility, your lower limb mobility. Bone density can lead to secondary complications such as spasticity and neuropathic pain, bowel and bladder dysfunction, sexual dysfunction, and pressure injuries, which is what we're here to talk about today. But one of the things I want to key in on is those cardiovascular complications. So this can result in reduced circulatory function. It can reduce blood pressure control, either through orthostatic hypotension or hypertension, which is a low blood pressure or a very high blood pressure, as well as your ability to elevate your heart rate. Next slide, please. So as we get into pressure injury, I want you to remember that there are three key factors that are risk factors, key risk factors for pressure injury. That is reduced mobility, which is common in persons with spinal cord injury, reduced sensation, which is also very common in persons with spinal cord injury, and reduced circulation. Without the ability to move, feel, or for the blood to flow into those tissues, that really is truly the trifecta of high-risk factors for pressure injury, which is why pressure injury is such a danger to individuals with spinal cord injury and is so prevalent. As you can see from the top right of this slide, up to 95% of people living with spinal cord injuries will experience at least one pressure injury in their lifetime. This can lead to long stays of immobility and bed rest. This can lead to amputations in severe cases, and is also a high factor cause of death in spinal cord injury. And across the bottom, you'll see the various stages of pressure injury, which we'll talk about a little bit later with Spring, moving from stage 1, which is a small red a small red marking, to stage 2, where we're starting to get an open wound. Stage 3 is when it moves beyond just the outer dermal layers and into the fatty tissue. And stage 4 is when it's gotten through the fat, down past the muscle, and into the bone, where it can really start to be a real difficult wound to try to heal. So with that, maybe we'll move to the next slide.
So stories, we know, are evocative and powerful. And Arthur Frank reminds us that stories animate human life. They work with people and always on people, allowing us to see what's possible, what's worth doing, and what's worth avoiding. Today, our panel will share stories of health journeys, stories of team building, and stories of coming together to bring about change. And we're going to start this by hearing from Spring and learning more about how this project came to be.
Thank you so much, Davina.
Oh, sorry.
This is my story of pressure injury. I will just take you through my experience with pressure injury as a person with spinal cord injury. I'd like to start by just saying that I'm sharing this story because I have a sincere desire and hope that it can be used to inform and to improve systems of care for people with spinal cord injuries, and that others who acquire a pressure injury will have a shorter and easier path to recovery than my own. So 6 years ago, in August of 2016, my personal attendant noticed a red mark on my bum. I'd been doing some outdoor activities and I thought that it was probably just bruising. But when it was still there a week later, I did have it assessed by a community nurse who advised me to continue just treating it sort of with a dressing over top. It didn't get better though, and so I called the RN again a week later, and by this time it was clear that this was a pressure injury. And so I began regular treatment with various dressings and packings. But by early November, the wound had grown. I was quite ill by this time. I was in severe pain and I was losing weight. I'd seen my GP and I was still seeing the wound care nurse regularly. I was on a back therapy treatment. But at the same time, the nurse that had been visiting me regularly had also told me that she, for some reason, wasn't going to have time to continue treating my wound regularly. I was pretty desperate, so I called a friend who was a physiotherapist. And she came immediately and she was really horrified at how I looked. And she must have contacted my GP because he called me to come to the hospital. And after he did an examination, he referred me to an orthopedic surgeon for a bone biopsy. At this point, I had not yet been treated for any infection. So several days later, I met with the orthopedic surgeon and he examined me and immediately diagnosed me with severe infection, a stage 4 pressure injury, and osteomyelitis, which is infection in the bone. It was in my right ischial tuberosity. He ordered a PICC line to be installed in that moment there in the hospital where I was, to begin intravenous antibiotics, and immediately asked that I be admitted to the hospital. At the same time, on the advice of my aunt, who is a retired wound care nurse, I requested urgent referral to a plastic surgeon. I was an inpatient in the hospital for 6 weeks with intravenous IV antibiotics and wound care. I was discharged then around Christmas when the infection had cleared, but the wound was bigger than ever. So at this point, this has been, I believe, 4 months into my pressure injury story. I returned home to lay in my bed. And when I say lay in bed, I mean I laid in bed, flat in bed, not sitting in bed or rolling in bed. I was finding it very challenging to get accurate info on the status of the wound because depending on who did the assessment, I would have different information. So it was really hard for me to understand exactly the status. I became very concerned with the quality of the care I was receiving. In February, I finally had a virtual consult with a plastic surgeon who advised absolute horizontal bed rest. It had now been 6 months since the PI began. In March 2017, I was readmitted to the hospital with another infection. I received IV antibiotics for 3 weeks in the hospital before I was discharged again. There were barriers to having further consults with plastic surgeons. By this time, I'd been on horizontal bed rest, complete bed rest, for 4 months. I knew that people with spinal cord injury often die from complications of pressure injury, and I was literally afraid for my life. And I began to make plans to relocate. In April, I moved to a larger center, which is an entire another story for someone with a spinal cord injury who uses a wheelchair and needs accessible housing. Once I'd moved, I attended a community clinic for wound care every other day. The wound stabilized and didn't become reinfected, and I began to hope that it could heal and I could avoid surgery. The wound did remain stable, but it also didn't heal, and by September, I'd been on horizontal bed rest for over 10 months. My healthcare team seemed satisfied because my wound was stable, and it felt like I was the only person that was concerned about the fact that my life was on hold, and it seemed like indefinitely. I didn't have an anticipated end to the situation, and my mental health began to deteriorate. I then made my own decision to start getting up for the main part of the day and to continue to monitor the wound for worsening. By November 2017, it had been 14 months of every other day appointments while at continuous risk of reinfection. I again requested a referral and was accepted as a candidate for plastic surgery. And on March 6, 2018, I had successful flap surgery and bone reduction. I had a 6-week recovery period in the hospital before returning home to start my life. From start to resolution, my journey with a pressure injury lasted 20 months. During that time, I had well over 300 medical appointments, and it was due to self-advocacy that it did end when it did. And just to contrast, recovery from a traumatic spinal cord injury involves 6 to 8 months in the hospital and rehab. And there's a great urgency, a focus on gaining independence, on healing, and there's always an expected outcome. But my experience with pressure injury was the opposite. There didn't seem to be an importance attached to resolving my wound, and I sensed that the situation would continue indefinitely if I allowed it. I experienced extreme psychological trauma due to the lack of awareness for the profound impact it was having on my life. Septicemia from pressure injury is a leading cause of death in tetraplegics, and I knew that I was in danger every single day. Thank you.
Thanks, Spring. That's a powerful story. I think Spring has touched on very succinctly the impact that a pressure injury can have on an individual with a spinal cord injury, and the long time it took to heal, as well as the real intensive amount of medical care that she required. We estimate that there's about 8,000 people living in British Columbia with traumatic spinal cord injury. And we know that pressure injuries in that population cost the British Columbia medical system about $50 million a year. This is not something that heals quickly. This is not something that heals easily. It's highly costly, not just to the healthcare system, but as you've heard, to the individual themselves. And so as an organization, the Praxis Spinal Cord Institute wants to better understand this challenge and wants to look at understanding the experiences of individuals. And so in 2017, we conducted a series of meetings throughout the province of British Columbia to talk to people living with spinal cord injuries about their experiences and to better understand the challenges they face in navigating the healthcare system and managing their pressure injuries, as well as to provide education on the latest developments in managing pressure injuries. And it was at one of those talks that I first met Spring. Spring was one of our speakers and delivered the message of her pressure injury story to our audience that day. And it resonated as powerfully then as it did today. We continued on, and in 2019, a meeting was held in Kamloops, special meeting on wound healing. And again, my organization supported the attendance of individuals living with spinal cord injury to participate in that meeting, including Spring, as you can see in that picture on the right. And it was at that meeting that Spring suggested to me and some others at the meeting that her story would make an ideal case study for the challenges in navigating the healthcare system and managing pressure injuries and spinal cord injury. And through that, we connected with Dr. Nicola Waters, who decided that she was interested in taking up this research project on behalf of Spring. And it was shortly thereafter that Davina reached out to me and said, "Hey, John, I see that CIHR has these grants available. I've always been interested in working in pressure injury or in spinal cord injury. Do you have any ideas?" And I immediately thought of Spring and I thought of Nicola, and we connected together. And I believe that the three of them got on quite rapidly, and we started to formulate an idea for how we could create a patient-driven research project based on the experience of Spring and the questions she had about her journey through the healthcare system. And maybe I'll hand over to Davina to talk about the funding proposal we put together.
Yeah, I would say it was a bit serendipitous. We all met each other in different ways. I had known Nicola as well in different ways. And so slowly but surely, I would say the stars aligned and we were able to work together. And I think a central part of that process was centralizing that lived experience. And so for us, it was Spring's journey and Spring's words that helped us reimagine what this research could be like and how we could do it differently, and to really adopt that patient-driven, patient-led, and we use the word patient as it's used by CHR, our funder, which does include people with lived experience and patients in the public, but we recognise that it's a problematic term in its own right. And as part of that process of team building, as say a funding opportunity was available to us, it was a good fit as well, and so we were able to move together to work. And part of that process, really, again, that centralising that lived experience and placing that explicit value on that experience also meant thinking about how we work together as a team. And so we know that there's increasing interest in how research environments and ecosystems contribute to meaningful partnerships. And over the course of this project, right from the onset, our team spent considerable time thinking about our partnership, thinking about the ways that we work together, and thinking about how to develop this process in a way that's safe and inclusive. And we built upon those early movements of nothing about us without us, and also recognized the opportunity of patient-oriented research in shifting the health research landscape to one that centralizes the experiences, needs, values, and priorities of people with lived experience. And so before we go any further with our findings, I wanted to head back over to Spring and ask you, what do you think contributes to a safe research space?
Thank you, Davina. And I just wanted to also say thank you so much, such gratitude to John and Dr. Waters and to Nicola for, for being open to working together to do this. And I think this experience for me has been probably transformative. The relationship has just been one of deep respect, of always respecting each other's expertise and experience. Something that I really appreciated and made this a safe research environment was the conscious desire that our team has always had right from the beginning to be equitable in the relationship and in decision making. I've been in situations before as a person with lived experience where you're sort of expected to contribute your time and your knowledge and your experience and even your personal story, and it may or may not be valued. It may or may not be used in a way that is respectful of your contribution and your experience. So that has been something that for me has made this work not only safe, but important and impactful. In the past, yes, like I said, in the past, I've contributed time and stories without having a return. So this was right from the beginning, a conscious and intentional process to support a partnership and to value all of the time and the knowledge that was provided. And another part of it was also just the giving respect to not only to myself, but to the participants for the fact that their journeys may be traumatic, and sharing those stories and putting them into the public sphere could also be traumatic. So giving a lot of space and respect around that. So I also hope that this research that is sort of driven by a patient or a person with lived experience perspective is considered important in the realm of policy and planning and best practices, because it is especially relevant to the end user, to the person that it is, the people, the audience that it is affecting. It should be, I sometimes make the comparison, we were talking about this earlier this morning, about how a lot of times the research and people who maybe don't have spinal cord injury are designing research projects about walking or about being ambulatory, when if you ask a person with a lived experience, that's probably down on the list of priorities of things that they would like to have researched and addressed, probably well down the list, below things like bowel and bladder function, temperature regulation, etc. So that's my hope, that's my goal, from this research, that it can be really used to change the way our system operates.
Thanks, Spring. Yeah, and you know, I think we just want to elaborate on that, is that this is not a patient-partnered project. This is a patient-led project. You know, Spring is a person with lived experience of spinal cord injury, and this was a question that mattered to her because of her experience. And I'm so grateful to CIHR, the SPORE initiative, and to organizations like the BC Support Unit. I've had a spinal cord injury myself since 1993, and the concept that a person with a lived experience of a health condition could be the leader of a research project is so novel. And it's really the way of the future. And I'm so proud to be a part of this project. And I'm so proud to come from a country like Canada, where we are leading the world in some of these methodologies. And I think, you know, when we're looking towards research having a true impact, health research having a true impact, this is the way forward. You know, and I'm really proud to have been a conduit for helping bring this team together, and to have helped provide some guidance to the team on methodologies to use. And obviously Davina's hugely experienced in partnering with patients in her work. So maybe I'll hand over to you, Davina, to talk a little bit more about that.
Yeah, and I think, you know, as a team, I think we were very intentional from the start in recognizing that there are many different systems and structures that impact on experience, but also impact on the way we choose to do our work. And so really challenging ourselves, I think, to actively include people that have diverse perspectives and diverse voices, and creating the spaces to allow those experiences to shine through in our work. And actually, I think it leads us quite nicely into the next section now, which is the second part of our panel, where we begin to explore more specifically the lived experience of pressure injuries in persons living with spinal cord injury. And here we're going to take a deeper look at some of the things that we've been working on, and in particular focusing on the interviews. And so we'll just quickly go over to John, who's going to introduce our goals and research questions.
Thanks, Davina. Yeah, so following an integrated knowledge translation model, we worked together. We brought the experts that we felt were needed in this team, beyond the research methodology, bringing in KT leads, clinical partners, and experts who really have the knowledge that we needed to formulate a research question and a research protocol that met our needs. You know, and really looking through IKT at engaging the right research users at the right time throughout the entire research process, and providing the structures for shared decision-making in research co-production. And as a result of those conversations, the research questions that we landed on were: what are the experiences of preventing and managing pressure injury in adults with traumatic spinal cord injury in British Columbia? What are the major patient-identified factors that impact individuals' interaction with healthcare services? And what are the patient-oriented research priorities for pressure injury prevention in management of people with SCI? So really focusing on the individuals first and foremost, and we'll touch a little bit later on about reaching out to clinical and health systems at a later date.
Great, thank you. Sorry, the slides are a little bit slow to advance. There we go. And so the project itself is situated within a broader range of activities, and we won't be presenting these in detail today, but our first phase involved counter mapping, and so arts-based mapping with people with lived experience to explore journeys and experiences. And our second phase is really our chance to learn through the experiences of others, so the use of in-depth interviews, and it's where we'll be focusing our attention today. And then finally, we'll be moving into some more priority setting in the hope that this is going to situate us well for some future and ongoing work. Again, I think we all came into this knowing that this would be a long-term partnership and commitment to change. And so really looking into how we can move those forward. And as we've said before, we really draw upon those principles of patient-oriented research integrated knowledge translation, but also some of the principles of institutional ethnography. And from that, we're drawing upon recognizing those systems and structures of power and how those can impact our experience, as well as taking a specific stance to view the standpoint of the person with lived experience. And so now we're going to talk a little bit, just very briefly, about our collaborative analysis process. And in particular, I wanted to hand over to Spring, for Spring to reflect on some of her experiences of being engaged in the analysis of the interview data.
Thank you, Davina. So yeah, this was a really interesting experience for me because I'm not, a researcher. So I was part of the analysis, the collaborative analysis process. I attended some of the analysis sessions, and I just found it very fascinating to be able to hear and see other people's stories, and then also just to take part in the process and the work of finding the themes and patterns. And I think for me, I was able to share my perspective and sort of from my lived experience, asking some questions that may not have been asked if there wasn't a person with lived experience there taking part in that process. So it was very interesting process for me. And I think one of the things that we were able to identify was just the fact that so much spinal cord injury and pressure injury prevention information is really directed at the individual. And one of the things that I was able to sort of to highlight is that sometimes those barriers that people face are beyond their control. So there's some systemic barriers there that may not always have been, noticed or acknowledged in other contexts.
That's great, thank you. And now we're going to have Nassim talk about some of our emerging findings. So I'll hand it over to you.
Thank you, Davina, and thank you, Spring. It's been a true honor and privilege to work with you and really to learn from you. So we'd like to first acknowledge that there's really no one single experience that can speak to the many experiences of persons living with spinal cord injury who have experienced pressure injury. However, that being said, using Braun and Clark's 6-step thematic analysis approach, we have generated some key preliminary themes that we'd like to share with you. And also, in addition, we'd really like to highlight some of these quotes to illuminate the voices of the persons who have lived with spinal cord injury and who've experienced PI and who have shared it with us. So fear of pressure injury and the potential for severe complications is a fact of life for persons living with spinal cord injury. The participants who engaged in this study shared with us that regardless of how they came to learn about pressure injury, whether it be through formal education during rehabilitation or whether watching their friends and their peers struggle with challenges of having to manage pressure injuries and its complications, they face this day-to-day fear of pressure injury that can happen and the severe complications that comes with it. I have 2 quotes here to share with you, but I will read one of them. For me, it stuck. I had a few friends like in GF Strong that had some pretty severe pressure sore issues. And so I kind of got scared of pressure sores right from the get-go. It was a big fear of being in a wheelchair that was going to be the one thing that was going to take you down. With this knowledge of pressure injuries and its severe complications and its fear, then prevention of pressure injuries is a primary goal of persons living with spinal cord injury. And I think this quote here really illuminates that. Prevention, prevention, prevention. I say it on the form, I say it to my caregivers, I say it to my friends, because once you break that skin, it never heals quite the same and it's hard to come back from. And I've seen firsthand the weeks and the months. And this person's referring to weeks and months that it can take to manage pressure injuries and to heal. Next slide, please. Prevention of pressure injuries was described by the participants in the study as involving continuous and vigilant monitoring by the person living with spinal cord injury. The participants in the study described many different ways of preventing pressure injury, whether it be using mirrors, using photographs to take pictures, using your care provider to check your skin, using specific high-tech wheelchair or cushions. But what was a common experience amongst all participants was this notion of continuous and vigilant monitoring from the minute that one wakes up to the minute that they go to sleep, from going from room to room, from seating to seating, even when going to high altitudes, if going for traveling. And I think this last quote here really illuminates that. So I've been 15 years with that mantra. We check the skin every morning, every night. I make my caregiver stare at my butt. Ain't pretty, but you know it's necessary. And then pictures, there are like 2,000 pictures of my butt on Google Docs somewhere. Just like get a mark, check it, check the next day, because we're talking a self-inspect with the whole 2-mirror thing press quads. So that's not really feasible. And luckily cell phones are real handy. Next. So this idea of this continuous and vigilant monitoring to prevent pressure injuries and then having to manage them if they do take place was described as continuous physical and psychological work with sometimes negative psychological impacts. And I believe this last quote that I have on this slide really speaks to that. It's cancerous. It kills me. It breaks my heart. And at the same time, having to change the dressing every day or every couple of days and seeing the deterioration of the skin around the wound is very psychologically damaging. It's ruled my world in so many ways, the emotional and psychological damage that it's caused, and living in fear all the time. It's PTSD. Every time it happens, just takes you back to that worst feeling in that worst place. The emotional, psychological is pretty much 24/7. And the abrupt cases of real deep physical deficits are occasional, I guess, rather than 24/7. Next slide. All the participants in the study spoke to the system failing them, where there's systemic structures that create barriers and inequities, whether it be for pressure injury prevention or pressure injury management. And these structures and barriers that create inequities kind of pointed to many different things, one of which was equipment and access to proper equipment. So having the right chair, having the right cushion, whether in the community, in the home setting, or in the hospital, is key to pressure injury prevention and key to pressure injury inhibition of its progression. And this lack of access to these equipment was highlighted by all participants. Another component another structure that was highlighted as creating barriers and inequities was this idea of lack of the knowledge of healthcare providers around spinal cord injury to begin with, and then pressure injury as a risk factor and how to prevent it and how to manage it. This last quote speaks to the lack of knowledge of healthcare providers. So the average nurse may be heavily experienced, but they're not experienced in spinal cord. Paramedics aren't experienced with it, spinal cord injury and pressure injury they're referring to. So I arm wrestled him, speaking to a paramedic. We were sitting in the bathroom of the lobby of the hotel, 2 or 3 paramedics and me for about half an hour. Next.
So next we want to thank you so much, Naseem, for sharing those emerging findings, and our team will be continuing to work on the analysis and interpretation over the coming months. And so we'd like to share a little bit about our knowledge translation plans and some of our next steps for this work. At the beginning, our team worked together to co-design a knowledge translation plan. This was right at the project inception. I think it's really important to note that we had a dedicated KT specialist, Charlene, who guided us through the process and helped us enact our patient-oriented commitment to knowledge translation. Our goal was to raise awareness of pressure injury risk and management in the hope that we could develop change in the health system, in policy, and in the research fields. We wanted to move the dial. And to do this, we knew it wasn't only working in a typical research audience way, we needed to engage diverse audiences in our work. And so we've been explicit right from the start in how we seek to serve and share our work with people with lived experience, as well as those in the healthcare system, healthcare providers, administrators, as well as more broadly, policymakers, those involved in patient-oriented research methods, and in health system policy more broadly. As part of our work, we plan to deliver diverse outputs. This includes those traditional things like manuscripts, but those were really last on our list of priorities. We wanted to serve our audiences and tailor our approaches. And so far we've included some presentations, but over the coming year, this will include more documentary type videos, infographics, plain language resources, as well as knowledge summaries and action reports that will be targeted to our diverse audiences. I'm going to hand over also to John now to speak to some of those next steps.
Thanks, Davina. So as you've heard, pressure injury is highly prevalent in persons with spinal cord injury. It's something that is a constant threat to their livelihood and their psychosocial well-being. And it's very difficult to manage and cost the healthcare system a huge amount of money. So with that in mind, we think about how do we move forward? How do we move towards a positive impact? How does this work lead to change? Over the coming year, we plan to bring together the stakeholders, to bring together the research team, as well as people living with spinal cord injury. But as you heard, we've primarily engaged persons living with spinal cord injury throughout this work. We did have clinical experts as part of the team, but we haven't actively engaged them thus far. And so that is our next step, is to engage with clinicians and health systems to understand how this knowledge can be used to elicit positive change in the delivery of care and the management of pressure injuries for people with spinal cord injury. As Davina spoke about our ongoing KT activities, speaking not just on the results of the research to spinal cord injury and pressure injury audiences, but also to people interested in patient partnership, patient-led research, and integrated knowledge translation, sharing to a wide variety of audiences and trying to help build up the knowledge in this area. Again, this was a team building grant provided by CIHR, and you can see the team is quite strong and quite diverse. And so we are now looking at emerging grant opportunities to move towards the phase 2 of this project, where we will look to actively engage clinical and health system perspectives to get a more fulsome understanding of this problem. And hopefully again, following an integrated knowledge translation model and consensus on what the questions that need to be asked are, we can help to inform potential system change to better manage the pressure injuries for persons with spinal cord injury in British Columbia and beyond.
That's great. Thanks, John. And I think just reiterating that approach to shared decision making and what's often termed as research co-production is, in whatever we do, in whatever way we want to move forward, we're very intentional in our process and in our work together. And so we're very excited to see where these next steps will take us. My screen's not advancing again. Sorry. And so here are a few more resources that we'd like to share with you if you're interested in learning more. Again, a resource that is great to give you more information around pressure injury, as well as more of an academic article that also speaks to the devastating consequences of pressure injury for persons living with spinal cord injury. And so as part of our work here and part of our knowledge translation and commitment to change as a group, is we're hoping obviously to continue to support the development of resources that really prioritize the needs and those values and those priorities of people with lived experience. And so we've come to the point in the presentation where we'd love to invite you to ask your questions, to ask for feedback, and to ask us perhaps to elaborate on any parts of our process that you would like. And I believe, Shana, you're going to be coordinating the question period.
Yes, hi everyone. So we haven't received any questions in the chat yet, but if anyone has questions, feel free to use that and we can have the team respond.
Yeah, I'm looking, Shana, right now at who's all in attendance in the audience right there, and I see some names I recognize. Dr. Victoria Clayton is there. I'm sure she has some great questions. I see Larry Mraz from the support unit. He's there as well. I've got some current and former colleagues with Jill Kurban and Diana Tyndall. So don't be shy, everybody. If you've got some questions, we'd love to answer them. Otherwise, I'll just keep rambling here and you'll have to listen.
Maybe, John, maybe as a starting point for our group and our audience today had the pleasure of listening to Nassim, who's a trainee with the team as a postdoc research fellow. And Nassim, I wonder for you as a trainee, just to kick us off, what's been your experience as someone that's still in their kind of learning stage of their research journey in terms of working with a team like this? Like, we'd love to perhaps share that with the audience while we wait for a few questions to come in.
Thank you for that surprising question. You know, you learn about patient-oriented research when you're training to become, you know, a PhD trained researcher or postdoc. But I think for the first time ever, I actually appreciated and understood what that means and what that entails. And I really appreciated when Spring started to work with us through the data analysis. And I actually had a conversation with her, telling her, I fear of all the analysis that I have conducted thus far that has not involved persons living with whatever the phenomena that I'm studying and their experiences and their kind of angle and lens into the analysis. And I think I would have to say that it's going to be hard for me to go the other way now, to do research without the involvement and collaboration from the beginning of persons with lived experience.
Thanks, Nassim. So we have a question from Diana. Could you talk a bit more about how patient-led has worked? Patient-led, perhaps in contrast to patient-partnered.
Would you like me to kick off for that one? So I think, you know, patient-oriented research has really been a transition in the health research landscape. And you know, we've seen, and we're collectively here today at this conference celebrating the amazing and unique and vital contributions of patients to research in terms of their partnership. And I think what we've seen over the last 5 years is a real transition from research that has been like investigator driven, that discovery research, as they sometimes call it, to research that is more reflective on needs. And so I think for us, the transition is about really centering that lived experience, but really responding to those needs. And so, I mean, I think we've mentioned it frequently throughout our presentation, is that intentional process of sharing this research journey. And that is like, you know, co-developing those research questions and co-developing that based on the experiences of what we hear as well. And so I think a good anecdote of that is, you know, when we built the grant together and we had so many meetings, and I always say thank you to this group because they put up with us. Like, we had lots, I mean, I think I can't overestimate how much conversation we've had along the way. You know, as we opened our grant with Spring's words, and Spring, I hope you don't mind me saying, like, I remember very much that meeting when we had met and you'd said, my pressure injury was worse than my spinal cord injury. And for us, that was like, and particularly for me, that was, you know, I come here with research skills. I do not come here with that lived experience and that depth of knowledge. And so it was a real humbling moment for us to look back and reimagine, you know, we just reimagined the research, you know, and it changed the way, you know, we just asked different questions. And so for me, it's about being intentional and meaningfully, you know, being prepared to walk the walk of, you know, don't just ask for experiential knowledge, respond to it. And maybe I'll ask either Spring or John if they have anything to add to that kind of patient-led thing, because it's something I think we're really proud of as a group.
I could just really speak quickly to that, Davina. Because this is my first experience with any sort of research project, I don't have a lot to compare it to, but as we've gone forward and we've just, you know, worked together as a group and talked about this experience, it's really become profound to me how different it is than a research project that is that engages perhaps or asks for patient input further on in the process. So the process, the entire process would have been designed from a researcher's perspective, and then in sort of seeking out a patient input at some point in the process, as opposed to the way this team has literally structured the study to respond to questions from a lived experience. And I can't tell you enough how important I've found that to be, and how much I've appreciated that, and how much I really just think this makes such important work.
Yeah, and maybe I'll touch on that as well, is that, I think it's fantastic that we have researchers like Davina and Nicola and Nassim and Shayna who are interested in working with people with lived experience and answering questions that matter to them, and having organizations like the BC Sport Support Unit that provide the resources and tools and knowledge to help us conduct work like this. And maybe I'll loop in. I see there was a question from Larry as well around, what advice would I give to a patient who's interested in getting involved in patient-oriented research? The first and foremost thing is it needs to be something that matters to you. I always say you can't just see a random person with a spinal cord injury on the street and say, hey, do you want to be interested in my research project? It needs to be something that's meaningful to them. It needs to be something they've lived, something they've experienced, something that has affected them, to be relevant to them, to be meaningful to them. And so I often say, it's the person with lived experience's job is to bring their experience and to teach the researchers about what it's like to experience that aspect of a health condition. And it's the researcher's job to help formulate that into research methodology and inform the partner on what the abilities and limitations of research are, and how we can take that idea, that question, that concern, and shape it into a research protocol that can come to an answer and inform the challenge that people are facing.
Fantastic. So we do have a question from Victoria. This has been such an informative project. I'm curious to learn more about how you will disseminate your findings beyond traditional KT. Of course, partner organizations like SCIBI are fabulous in this regard, but how can we extend our reach further?
John, do you want to kick off?
Sure. I think from the outset, when we first did these community acquired pressure injury meetings throughout the province, and invited people with spinal cord injuries to participate in those and attend the Kamloops meeting where this whole project kicked off, the ultimate goal is to try to change the system. And so, I think infrequently researchers are looking to health systems as key partners. And that, I think, is one of the key areas of knowledge translation, where we need to engage with clinicians and health systems, make them aware of the work that we've done and the knowledge that we've collected, and move towards informing not just hospital systems and regional health systems, but the provincial ministries, so that they can use this information to make informed decisions about the future of care delivery. I think there's always the idea to share this knowledge with people with lived experience or other researchers, but if it doesn't affect the health system, it is unlikely to lead to true impact.
And I think I could add to what John had said, and we spoke a little bit about it earlier in our presentation, is that, when we were doing this work, we had that intentional process of engaging different partners that that also brought different expertise, but also different networks. And so, one of the things is also like challenging each of us to explore how our own networks can help support that process of knowledge translation and mobilization, but also at the same point, and I think Spring, you have done this so many times in such a fabulous way, is asking the question, how do we reach out to people whose voices are typically considered hard to reach? How do we strive to embrace considerations of inclusion and diversity? And those are questions we also have for our knowledge translation, and we continue to stretch ourselves, and again, reaching out to existing networks and and asking, like, how do we best, share this work? Where are the avenues we haven't thought of? And again, I think one of the upcoming projects that's being supported by Praxis and we're really excited about will be a couple of like mini documentaries, videos about the work, and that's going to capture some of the real life kind of work that we do together. And again, we just hope that those different ways of sharing our message is going to help us continue to move forward. And also, I think that dogged determination, I think, of wanting that change and being committed together. And it's not something that was taken on lightly when we all came together. We knew we were together for the long haul. And I think, kind of linking back to an earlier question, as a researcher, it also meant leaving the ego at the door, listening and knowing that all of us here have our different skills that we're contributing, and that there's no one person that's got it all. We're to collect. It's a collective mission, and so that.
I just want to jump in with one last thing. I see a question for Veronica Caparas about how to engage with persons living with a health condition. I think oftentimes researchers may be waiting for persons with lived experience or a health condition to come to them, to come to these scientific meetings or to engage with them. But this is a two-way street. Researchers can take that initiative, can reach out to people living with that health condition, whether that's through social media groups, whether that's through support groups, whether through that's community events, and go out and actively engage with them, get to know them, develop those relationships, and ask, how can I help? What matters to you? And if you go there with that open mindset, with that ability or willingness to engage and build relationships, the questions will come to you, and the partners will make themselves known.
That's great, thank you. So I think that wraps us up for today's session, and I'd like to thank everybody for joining us today, and a true thank you so much to our panel members today that have shared their stories, shared their experiences. We hope you've enjoyed it. We invite you to reach out if you'd like to hear more or learn more about the project, or just connect with us and chat. We'd love to connect. And we thank you all so much. Thank you.
Thank you.
Thank you.
Thanks, everyone.
Thanks again, everyone. That was a fantastic example of patient-initiated research, and really is exciting for where we intend to go with the future of this. So I again, fantastic work. And I also just want to chime in, and now looks like we'll have a little bit of a break, and now just to remember to take a look at some of the posters on through the main menu on the platform, and remember that if you are going to take some social media posts, to use the hashtag PPF2022 for any of those posts, and feel free to drop by and take a selfie using the live snap feature on the left hand side within the main menu. So we'll the next set of breakout sessions will start at about 1 p.m. So thanks again, everyone. That was a fantastic presentation and really wonderful to hear. So have a great rest of everyone's day.
Thank you.